Hi, this is the 18th of February, 2018 in New Zealand, and today is actually one of my favoriteest subjects. I mean, all of these talks, the series on debunking the myths around childbirth and talking about the truths about childbirth are really what I love doing. I am not a midwife. I'm the director of Common Knowledge Trust, which is a New Zealand registered trust. I had the privilege in the early 1970s as a body worker to work with hundreds of women then my age whose bodies had been damaged when they gave birth, and pregnant women who had either given birth before and had a birth story or were about to give birth and were trying to figure out their birth. I certainly couldn't do anything to change where they birthed or who they were going to be with, but we could focus on the body. And the first inkling we had that we could develop a skills-focused approach to all births, a universal approach, came from a woman who had a sore tailbone after her birth. And I felt her tailbone, and it was as long as my pinky, that long. And I thought, wow, that's interesting, because I felt mine, and mine was that long, just a tiny little nib. And I had given birth in 1970, and my tailbone hadn't been hurt. And then you'd hear stories of women who said, oh, I had terrible pain in my hip, or I had back labor, or my baby didn't come into the pelvis, I didn't dilate for hours and hours, or I pushed for hours and hours. And what was apparent was that that had to do with the body. It's the relationship of the baby to the body. So could we develop skills that would help our baby come through our body more easily? Or were we just stuck with those things? And what we realized was, yes, we could. Now, it took us 15 years to develop those skills. And we also focused on very simple things like breathing in birth, how we communicated to our partners who were now permitted to come into birth. How could we have a type of touch that we really liked rather than wanting to push a person's hand off of us? How could we cope with the pain? What were we saying when women would say, you know, at first the contractions weren't too bad and I found that I could cope well with them. And then they got really painful and I couldn't cope. So what were we saying? What were we saying to each other when we talked about this niggling labor that went on and on and on? Was there anything that we could do? At that point, it was try to get your labor going, walk a lot, stimulate the nipples, have sex and have an orgasm. And yet too many women would say they tried that for hours and hours. They didn't sleep. They just kept trying to get their labor going. They tried herbs. They tried all this stuff, and they just got exhausted. So we knew that something wasn't right. And we had to couple that to what was already available. And when I gave birth in 1970, and I've since moved to New Zealand, so in the history of New Zealand, the same thing sort of happened in the 50s. In the 50s in New Zealand, the Parent Center, which is the childbirth education group in New Zealand, was formed. So it was formed around Grantley Dick Reed's childbirth approach, which was birth without fear. So his approach was that women shouldn't be afraid of birth, and that there were some breathing techniques and relaxation techniques that women could use in order to achieve a natural birth, a pain-free labor, and one without medical care. In the United States, there was Lamaze, which was probably taught at every hospital in every small town through every big city. Everyone took Lamaze. It was a societal expectation. And then the Bradley method was people paid for as sort of like a more upmarket, exclusive kind of a course. But those three male obstetricians developed these systems around a time, it was post-World War II, where maternity care began to really be sort of a narrowed specialty, and more women were coming into hospitals, and the standards of care were placed on everyone. And these men were thinking, we don't need that all the time. We need it for problems, but we don't need it for everybody, because women have always given birth. So when I gave birth in 1970, there were these breathing techniques. Lamaze was, we were supposed to lift the diaphragm off the top of our uterus, which would decrease the pain. Bradley method was in the nose, out the mouth. Try to relax. Some women found this successful. Too many women didn't. And the Grantley Dick Reed in New Zealand was the same thing. So for a generation of women, 30-year period, women went to learn these techniques with the hopes of having a natural birth, which at that point still was not defined. It already, well, what did that mean? Was a dead baby natural? Was a woman tearing natural? If a woman had postpartum hemorrhage, was that natural? If she had a long labor or pushed for hours, was that natural? So natural birth was already being co-opted to mean easy. And so these techniques wanted the women focused on, I'm going to learn these techniques in order to achieve this natural birth, this easy birth, pain-free labor, that implies easy, and without medical care, so that somehow my using these techniques would limit the amount of medical care that I experienced in birth. So for a generation in New Zealand from the 50s into the mid-70s, and in the States from the 60s through the late 70s, Grantley Dick Reed, Birth Without Fear, Lamaze, and Bradley method were taught, and people were trying to seek these three goals. But they didn't work. And there have always been birth advocates. Birth advocates come in two forms. They come in the form of midwives, and they come in the form of consumers. So midwives want to advocate for a new type of delivery of service, which is based on normal births. So for years, when I would listen to the discussions from midwives, it would be, we are the best providers for low-risk normal births, which meant that only women who were perceived of as low risk would then be entitled to midwifery care. And thankfully in New Zealand, when midwives became the lead maternity carers in 1990, they said, no, we want to give continuity of care to all women. But philosophically, their profession aligns very clearly with a fundamental message that they give, that pregnancy and birth are normal life events, which they are. But once again, that word normal is co-opted to mean without risk, without medical problems, and because New Zealand midwives are giving continuity care to everybody, many, many women come into pregnancy with medical issues that need medical care, or develop them, or their baby develops them, or those problems developed in pregnancy or in birth. So the techniques sort of failed, and birth advocates, that in a new group that came up in the 70s when I became active in this, was that they looked at the skills and said skills do not achieve a sufficient number of natural births, pain-free labors without medical care. So if that doesn't work, those techniques don't work, we're going to turn our attention to giving women choices. And so there was a lot of political movement at that time. Midwives wanted to give the choice of home births. In a lot of countries that existed. Midwives also wanted to be an autonomous profession. They also didn't always want to be medically trained, be a nurse first. So there was a activity around midwives becoming direct entry midwives as they are in New Zealand and an autonomous practice. From the consumer viewpoint as birth advocates, they were advocating for home births, they were advocating for water births, and they were advocating for women's ability to say no to what had been known as medical assessments, like checking your heart rate or doing a vaginal exam or checking your temperature or monitoring. Fetal monitors began to be available rather than a periodic check with the stethoscope, or procedures such as rupturing your water, stripping your membranes, induction of labor, getting labor going, augmentation of labor, forceps. Ventouse became popular instead of forceps, or cesareans. But in 1970, when I gave birth, the cesarean rate was 4.5%. But they were very dangerous then. You were cut from your pubic bone to your navel. You were given a general anesthetic. And it was very dangerous to get pregnant soon afterwards. And after 2 cesareans or 3 cesareans, you're encouraged not to have more children because of the potential that your uterus could rupture. And my sister-in-law's uterus ruptured when she was in the latter 9 months of pregnancy. She lived, but the baby died. So I know that that was a real issue. But then they changed how they did cesareans into the bikini cut, because women wore bikinis then and wanted not to have this ugly scar. So the medical profession has changed. Women are now awake. Fathers are now with them. So everything has changed, except we got stuck with these techniques that were trying to achieve these 3 goals of a natural birth, pain-free labor without medical care. So people focused their attention on choosing. So instead of using the word assessment, monitoring, and procedure, everything got lumped into the word intervention. So when you think of interventions, make a list of those. I've made a list when I've taught strengthening the partnership workshops with midwives in New Zealand, and they come up with 28 things. So we are saying to one another as women, if we want a natural birth, we have to avoid these 28 things. That makes it very hard for us. And once you say women should have choice, you have to accept that women are going to choose more medical care. Because in reality, in my lifetime of 45 years involved in birth, there is a tiny, tiny percent of women who are seeking less medical care around their birth, are trying to have a pain-free labor, and want to have a natural birth, or even a home birth, or even a water birth. It's a tiny, tiny percent of the number of women that are giving birth each year. Most modern women want their pregnancy and their birth to be embraced by modern medicine because it's so infrequent. It's as simple as that. And when I work in third world countries, not around birth, where there is no medical care, women want medical care around pregnancy and birth because they experience in their villages the devastating impact of birth trauma to their bodies, not to their minds so much because they accept it, they don't necessarily like it, or death or injury to the mother or to the baby. But the natural birth advocate consumers and midwives have been very politically active and organized, and they've had some very famous authors who have spoken on their behalf. And so they have pushed for positive change, which has been very good. But when we focus on choice, women know what kind of birth they want, and we can therefore plan it. We run up against those realities and the myths. So the reality or the truth, when we think about what we want at birth and that we might want to plan it, is that there's no way to know what your birth's going to be like. That's the truth, and it's always been the truth around the world. But that is followed by an untruth, which is therefore there's nothing you can do really to prepare for it. That's untrue. And those two things collide. A truth collides with an untruth, and we get caught as women in the middle of this. If there's no way to know what our birth's going to be like, is that just something that happens to us? Or can we really take control of this and plan it? We know what we want. We want a safe birth for ourselves and our babies. And the next thing we want is a positive birth. So we try to plan it. But when we plan it, there are many women who want to plan for more medical care because to them that is what's going to produce safety. And that is what's going to produce a most positive birth. They're okay with as much medical assessment, monitoring, and procedures as they feel their professional thinks they should have. And their professional is always working within the evidence-based practice or the standards of care of the day. And I've lived through 3 of them, so I've seen things change. So when we talk about techniques that we use as birthing women, if the techniques don't work for all of us, then we know they're techniques and not skills. Because 100% of pregnant women will give birth. This is a universal. We're all going to give birth once we're pregnant. And humans, women or men, all blink. We all cough, and we can all tighten up our rectum, which means we should have some ability to create a set of skills that all of us can use when we birth our baby. And this is what the Birthing Better skills are. When we looked at things like hip pain, we asked the question, can we create more space in our body? Yes, we can, and we have a skill called the hip lift. If we have back labor, can we move our sacrum in some ways, that triangle at the base of our spine, to help reduce that? Because the technique that people used was to push in on the sacrum, which closes the space that the baby's trying to create. And yes, we could develop a sacral maneuver, or Kate's cat, in order to create space. If breathing techniques like or the Lamaze in the nose, out the mouth, which sounded great, except you can moan and scream doing that, right? Then we had to look at how humans breathe. And we discovered there were 4 ways we breathe. In the nose, out the nose, in the nose, out the mouth, in the mouth, out the nose, and in and out the mouth. And in those variations were ways that we, each individual, could find to help us relax and cope. And that we could find variations within those variations that allowed us to adjust how we breathed and still coped. And they were sustainable. That meant that we could adjust them and adapt them and sustain them throughout our birth. We learned that there were ways that our partner could touch us, that could cue us to soften. We learned effective nonverbal and verbal communication to have a good team between ourselves and our partner or other who is going to be our birth coach. We found that skills could be used from the viewpoint of us as giving birth, as well as from our coach who is helping us stay in control and manage. So skills and techniques differ because techniques don't adjust, they're not adaptable, and they're not sustainable, whereas skills are, and Birthing Better skills are. So I've come to the end of this talk about the difference between childbirth techniques and skills. We are a charitable trust, and we want to grow a skilled birthing population for all of you, all of your friends, all of your relatives. But you have to help. You have to tell people about these talks and be able to explain it to people. We accept donations through PayPal at info@birthingbetter.com. The myths of childbirth are on a YouTube playlist. These are on a YouTube playlist. comment on our Facebook page at Birthing Better Childbirth Preparation. Tell us what you want us to talk about so we can deconfuse childbirth and we can grow a skilled birthing population for all pregnant women so that they can, with pride and dignity, birth their baby. Talk to you again. Bye-bye.